Good afternoon, everyone. It's 12 o'clock. We will call the meeting of the Joint Board of Managers Meeting and Governance Committee at 12 o'clock, Thursday, April 25th. First order of business is to see if there are any citizens wishing to address the committee. Seeing none, I'll move and ask for approval of the minutes from February 28th. That's tab 4, page 3, also in the board portal. I reviewed them, did not see any necessary changes, but that's just me. So
if it gets through Chuck Weber, then there are no changes.
there are no changes.
That man watches.
I will accept Dr. Weber's motion and a second by Dorothy DeBose. All in favor? Any opposed? And the minutes pass. I don't have much of a committee chair report other than to say to Ron and to Michelle and their team, this is not a very large group of people that produce volumes and volumes of really good work on behalf of the hospital district. And I just wanted to give a public shout out to you all in our private meetings, and we discussed some of those things. And I just want to make sure that you and your teams all understand that we really do appreciate the work, and some of it is not very fun. So thank y'all for that very much. Okay. Item 5A, Ron, let's get the behavioral ERM update regarding behavioral health. Ms. Zelia's here today.
Good afternoon. Thank you so much, Mr. Chair, for complimenting the team. The team do a lot of hard work and trying to put this together for the district. We're going to start off today with a update on enterprise risk management, and I know I haven't met Amanda and Zim yet, but for their benefit, just a quick 30-second just context, and then we'll move on to Zelia's update. But our ERM, our Enterprise Risk Management Program, started about 4 years ago, and it is designed to identify key risks in the district related to us accomplishing our strategic objectives. And through the process we went through about 3 years ago in identifying 10 or 11 key risk areas, behavioral health being one of them, not to say that they're burning platforms, but to say that these are key areas to JPS's strategic plan and mission, that we designed a risk profile around these 11 areas based upon all the input from the board members as well as employees and leaders. And over the past 3 years in these 11 areas, have developed these risk profiles to determine, where we are in our journey toward getting to where we would like to be. It's not ever to say that we're ever done from a standpoint of high, medium, or low, and that's what we talked about 3 years ago, is that all of these areas are very big ticket items. And so, for example, in addition to behavioral health, one of the areas, for example, is clinical quality. And of course, the board has a committee on quality that goes through all the areas and aspects of that. And so it's really more of how are we doing in terms of our maturity in addressing some of the known and sometimes addressing the unknown things, that emerging risks that come up along the way. And so periodically I will have the executive owners like Zelia to talk about one of these 11 areas, to give an update on where we are with respect to our journey with respect to risk management. And so this year, it happens to be the 3rd year of the program, and so we're going to refresh this risk assessment, because it's, we need to do that from time to time and see if there's anything we need to add, or if there's anything that we can move from the 11 top areas to a more of a maintenance mode, that where we've gotten closer to where we'd like to be, if that makes sense. So with that, if we'll, let me click the slide. So this is just an overview summary that all 11 of the areas are summarized in. There's a lot more detail around each of these that we have, but we wanted to provide some talking points to have a discussion here today. And then the only other thing I'll say before Zelia talks is that the crescent graph that's on this slide, that kind of the dashboard slide, just to give a little orientation or refresher on that. There are 2 arrows on that slide. The black arrow is the baseline of where we were 3 years ago when we first looked at this metric. So that's pretty much a static line that doesn't move. And then the green arrow is the current state of where we believe we are today with respect to our maturity on the scale of maturity from initial from the left to optimized on the right. And then the white star that's currently in the managed category, which is level 4, is where the organization is aspiring to get to with respect to, in this case, behavioral health and from a risk management standpoint. So, so if you were to read that as it currently sits, is that we're in level 3 of maturity, and we're seeking to get further to do further work to get to level 4, if that makes sense. So with that, I'll turn it over to Zelia.
Thank you, Ron. Good afternoon. I wanted to kind of give you a brief overview of risks that we've identified and things we've done to mitigate those risks. And our definition, we changed our definition as well, in striving to transform behavioral health across the continuum of care to become a national model and standard of excellence. That's our goal here at JPS. And we are taking many steps in order to achieve that definition. There were a few areas of key risks that were identified. One is patients' lack of adherence to treatment, and that's not really on the inpatient level, it's in the outpatient setting, and once they're discharged from here, what are we doing to try to get them to adhere better to treatment? And why I identified that as a risk is because, we kind of have a revolving door sometimes with behavioral health patients. They come to the ER, they come to the Trinity Springs, they go home, then they come back to the ER, and that's not the most efficient way to handle their care, and it's certainly a more costly way to handle their care. And so we've put in place measurement tools and opened access in our outpatient clinics to where we now provide walk-in clinic appointments. So anybody can walk into our Hemp Hill Clinic today and be seen, screened, evaluated by a clinician. We have medication providers there to administer medicines and to start people on various medications, and that's something that we've implemented this fiscal year, which I'm really proud of our physician group as well as the clinicians in our outpatient clinics. That would be at our Hemp Hill Clinic, corner of Allen and Hemp Hill. Mm-hmm. It's the only one where you can do walk-in appointments. At our other outpatient clinics, we are available and have providers in our outpatient clinics to address those volumes on a scheduled basis. But if someone was in urgent need and their appointment was a week away, they could come to the Hemp Hill Clinic today and be seen.
Do we recognize the need that might need to be expanded?
We're potentially evaluating those opportunities, yes. Mm-hmm. I think the potential is there, yeah.
Those particular patients are kind of on a line, and depending on the mood, and okay, I'll go, but it's a 30-minute drive, never mind.
Right.
So.
Right. And those are things that we are currently evaluating, and we have we do have a clinic at the Trueworth Clinic for homeless folks. We offer day treatment programs for homeless individuals as well as medication management right there at the Trueworth Clinic, and so that has helped a great deal. But the biggest challenge is medication adherence, and that's clinical as well as other things. For example, a patient could be taking their medicines and they start to feeling really good, and then they think they don't need to take medicine anymore, and then they spiral downward again. And so those are some challenges we face as well. Another key risk is our inability to serve the behavioral health population. We have a large volume of behavioral health patients that come to JPS, not just at Trinity Springs, not just in the emergency rooms. And so some things we have done to mitigate that large volume, besides having an outpatient walk-in clinic, we've partnered with community behavioral health And we have behavioral health specialists at several of our community primary care clinics. We also have excellent standardized assessment tools that all of our primary care clinics utilize. And if someone scores a moderate or high risk on the suicide or depression screening tools that are implemented, it automatically sends a page to a social worker that has to respond within 15 minutes of getting that alert to assist the primary care physician or mid-level practitioner in that environment, up to and including sending them to the emergency room or Hemp Hill Clinic or one of our other clinics. And that has really worked well in the outpatient setting, and our primary care partners have really appreciated those efforts in helping them, and then also having counselors co-located in the primary care clinics, and a few of them has allowed for a patient, for lack of a better word, one-stop shopping, so to speak, at a primary care clinic versus having to go elsewhere. And so that has helped to mitigate that, and also increase volume outside of an emergency room. Workplace violence and injury, that's a big topic for us. We've made some great progress this fiscal year in reducing workplace violence and injury. One of the things we did with our physician partners was to create a agitation anxiety order set, and actually it's district-wide now for emergency room as well as the medical floors. So if a patient is anxious or agitated for whatever reason, the clinicians, whether they're a psychiatrist or not, can look at the order set and see what they need to do, and that helps decrease some of that anxiety and agitation, which decreases the potential for violence. We also developed, in coordination with Wanda Peoples, our CNO, a workplace violence task force committee, and we've made a lot of great changes on that committee as well throughout the network. One of the things we've done in behavioral health is we've got these personal alarms now that are really, really loud, piercing loud. And so if they feel like they're in a dangerous situation, they can push that button and staff respond immediately. But because it's so loud, it startles the patient as well, and it can stop the actions from proceeding further. So it's a win-win for us. And the staff have really, really enjoyed having that equipment available. We also have done other things, like we've got workplace violence signs now throughout the district, including Trinity Springs, that clearly identifies what's acceptable and unacceptable behavior in the hospital. And Wanda has worked very hard on this, and it's been a joy partnering with her on it. Workforce challenges. So when I first started here, we had a lot of vacancies in nursing. And so again, in partnership with Pia Walker, with Human Resources, and our recruiter, who is amazing, we have been able to reduce our vacancy rate to, I've got like 800 employees that report to me between the psych hospitals and corrections, and we're down to like 15 vacancies. And that's amazing, and that again shows the amazing work our Human Resource Department does and with recruitment and assisting us. Another big risk area that is a potential for us are inpatient suicide attempts and or successes. At Trinity Springs, we've done a lot of clinical work in that arena. We now have what's called zone coverage. I mean, of course, our mental health techs or our nurses do 15-minute safety rounds, but we also have zone coverage by the techs or the nurses so that areas are covered instead of numbers of people, and so we can have eyes on our patients. But technology also is improving our ability to minimize risk. With the board's approval, might have been a couple of years ago, we started doing ligature reductions at Trinity Springs. And one of the things that we did that you all approved as a board was putting door alarms over the bathrooms and patient doors. And that technology in and of itself has been incredible and has been great and has aided us in our ability to have a safe environment. Also, doing more training of staff and giving them more tools in their toolbox has also been effective. And so, as Ron told me earlier, I could probably talk the whole hour, but that's not my job today. So I'm going to now be quiet as Mr. Early's giving me the look. No, I'm just kidding. Just kidding. And open it up to see if anybody has any questions.
Anybody have any questions for Zelia? No, I think it's great. It is tremendous progress. I guess my question, Ron, is, and refresh, because it's been several meetings since we last talked about this, but how do we know the arrow moves, and how do we know the arrow has moved to the right spot?
It's a good question. It's based upon a calculation based upon 3 factors. And those 3 factors are metrics, which are organizational metrics, in this case for behavioral health, that are organizationally accepted. So we don't come up with these are organizationally accepted. Some of them are organizational AIP goals. Some of them, if they're not on the AIP list, there are other metrics that track progress. So that would be one dimension. The second one would be initiatives, many of which Zelia's touched on in behavioral health specifically, and how far along are we in those initiatives? Are those initiatives moving the needle as it relates to mitigating the risks that are identified here? And then the third one, which is a little bit more subjective, we haven't gotten as into this as deeply, is capabilities, risk management capabilities. So do we have the right people in place? And she talked about vacancy and vacancy rate. Do we have the right technology, which she talked about as well? And do we have the right processes to address these? And so based upon those 3 factors, there's kind of we normalize that to a 5-point scale to move the green arrow. And actually, it's a nice bridge into, we're going through a project now, mentioned last time, that we're getting some help from Grant Thornton to help standardize that calculation that I just referred to, so that when we present that, that it's take a little bit less subjectivity out of the process, and so that so you can see as we make progress in each of those 3 dimensions to how the arrow would move, if that makes sense.
Great, thank you. Anybody have any other questions?
I have one question. I know at behavior health you have assessments to looking for problems, but on the med-surg floors, when a patient is maybe having issues, how do y'all address that? I'm thinking about that because of what happened at Baylor All Saints.
Correct. So we actually have a full-time consultant service in-house. It's a full-time psychiatrist, a full-time nurse practitioner, and a full-time MSW. And so we are able to consult pretty quick, 7 days a week. But also, back to your concern, that's one of the reasons why Dr. Potawiltz, our chair, made our agitation anxiety order set go house-wide, is because you don't have to be a psychiatrist to order those medications. And that way, another physician with some information from nursing would be able to help that as well. We do have there's 2 more things that we're working on to address some of the needs on the medical side of the house, one of which is a behavioral health response code team. So you have your medical rapid response team, you would have a behavioral rapid response team, and act as a immediate resource for nursing, so that we can address issues quickly. And so Wanda is working diligently on that.
Thank you.
Very good. Zelia, thank you.
Thank you. I appreciate your time.
Appreciate it.
Let's talk compliance program.
Yes, with that being said, I'll move on to the compliance program updates. So as I normally do, I like to start out with what's happening in the industry overall in the area of healthcare compliance, and pull out relevant enforcement actions and other activities that take place that have some relevance to JPS. This first one is more of a local Texas story. Palo Pinto General Hospital in Palo Pinto County, their CEO faces 5 years in prison for allegedly allowing the hospital's national provider number national provider number to be used to bill for private insurance, private insurers like Blue Cross and Blue Shield and others for lab services that were never performed. Essentially what they were doing was, doing a pass-through billing for these lab services. They were never performed, and this happened over a period from September 2017 through June 2018 there. And so that case has not concluded yet, but the CEO was indicted, and there were a number of other co-conspirators named in that case that submitted these claims that they received fraudulent revenue amounting to about $55 million over that period of time. So, not to say that any of
patience.
what's that?
I said they had a lot of patience.
A lot of made-up patients.
Oh, yeah.
Yeah, in the years. The second case is a case with Skyline Urology, and this was a False Claims Act case. And this was a case where this urology provider provided outpatient urology services and was indicted for or fined nearly $2 million for essentially billing for services, overbilling Medicare for certain services. And so specifically for improperly using billing modifiers, which we've talked about a little bit in this committee, or actually a lot in this committee, and specifically for what's called Modifier 25, which means that if you have an E&M service that you can't bill separately or unbundle for that E&M service unless there's something significant or separately identifiable that justify it being unbundled and billed separately. And that's typically what Modifier 25 is used for. What the urology company was doing was essentially unbundling, did not provide that substantiation for why it was significant and separately identifiable, and therefore those were false claims and therefore needed to be reimbursed to Medicare. And so this happened over a period of 3 years and resulted in a corporate integrity agreement in addition to the nearly $2 million fine that required a third party to come out to the company and do quarterly claims reviews of their billing practices, specifically relating to modifier usage. So obviously I picked this case because we've talked a lot about modifiers here in terms of the audits that we did, and just kind of goes through the importance of kind of following up on those things. The last case is more of a national enforcement action that took place with the Department of Justice and the OIG, and this was really a tragic story, but basically several states over a period of time were involved in these fraudulent knee braces, neck braces, back braces for older individuals, and basically trying to convince them that they needed these braces when they didn't need the braces. And so they ordered the braces for them, sent them to them, and then they billed Medicare for them, and they were not necessary. And it happened over a long period of time, and it amounted to over $1 billion that they collected from Medicare for these fraudulent braces over a period of time. And what's sad about that situation is that many of these folks didn't need the brace, but if they ever did in the future, they had already kind of used their benefit as a result of now having filed this fraudulent claim. And so they're still working through that. But there were at least a couple of dozen people that were arrested, including physicians, owners of durable medical equipment, and many of these were done via telemedicine as well. And so this was a case with Department of Justice out of D.C. Had prosecuted, and this was out of this happened actually earlier this month, and was a pretty sad case. So, any questions about any of those three?
Thanks for the rainbows and unicorns.
Oh, absolutely. It's my yeah. If no other reason, I try to justify our existence, right? All the happy stuff. This last part of the update, periodically, and I used to do this a while back, but I'm going to get back to providing more board education on certain kind of foundational elements of compliance to kind of enable you to ask us whatever oversight questions that you'd like to ask us. And so what I wanted to do is just take a few minutes to review the elements of an effective compliance program as outlined by the federal government as relates to the federal sentencing guidelines. And these elements, even though we're in a healthcare organization, apply to all organizations that have a compliance program. And when a fraud case or an investigation or other kind of matter like the ones I just mentioned in the previous slide come up in a particular organization, one of the things that's a mitigating factor to damages and how much the organization pays is the effectiveness of the compliance program, because that can be a mitigating factor. Because if the organization can show that they actively and proactively identified, found, and fixed items on an ongoing basis without, having the government to intervene. And so these are the 7 common elements, and I'll just cover them briefly, and I'm certainly open to any questions. This first element is high-level oversight. And so when the guidance for hospitals came out, one of the things it talked about was the establishment of the role that I have, the compliance officer role, and that compliance officer needs to be objective and empowered to do their job without undue influence. And typically, although if you look at peer organizations across healthcare, the reporting structures change. Typically, the compliance officer ideally reports to the CEO and the board, which is the case here. And I've seen it where the compliance officer sometimes reports to the general counsel. It can work as well. It can be a little challenging, or sometimes the CFO, which sometimes can be a little challenging as well. But it can all those environments can work, is what I'm saying, because I've seen all of those environments work. But the establishment of a compliance officer, a board oversight, which what this committee serves as, which means that I'm accountable to you all as board members to relate what are we doing in our compliance program, how proactively are we being, and then thirdly, that we have a compliance committee within JPS or within an organization, which we do. Our compliance committee meets every other month, and usually before items come to the governance committee, we discuss them in our internal compliance committee before they come to this group. The second area is policy and procedures. So policy and procedure are fairly self-explanatory. All organizations have them. We certainly do. Our general counsel works with us on reviewing those that come to you for your approval. And we have at JPS, about 2,400 policies and procedures of various sorts and kinds, from clinical to non-clinical and so forth. But from a compliance standpoint, it's, do we have written policies and procedures? Are we auditing against those policies and procedures? And how do we know that the workforce is aware of those and are trained against those? And so that we'll touch on the training element here in a moment, but we also have a set of compliance policies that's a part of that goes through what we do around each of these elements and what our functions are. We also have security policies, which we'll talk about a little bit when David comes up, that we have a few to be updated here today. And then we also have a number of clinical policies and procedures. And policy and procedure administration also reports up in my group. I have a outstanding individual in Irena Hughes who administers policies on behalf of the district and working with the various department owners. Open communication, this is also just how do we communicate across the organization? Do we utilize organizational communication channels? So in JPS we have the huddle communications that come out once a week. We have newsletters that we can send out communications, which we do. We have leadership connection that happens once a month that occasionally that I and my team would send out messages. And then we also have the hotline, which all employees and or vendors have access to send anonymous or not complaints or grievances. Many of the hotline calls, and much of which I give you in your board packet in terms of what has come in the hotline, are HR-related matters, related to employee matters and those kinds of things. And so we coordinate with HR to handle those cases. But for every hotline case, we're required to open up an investigative file, to look into it, and then determine whether it has a substantiation or not. Training and education. Training and education is, how do we let the workforce know about compliance and the various aspects that's a part of their job? So much of that is in the policies and procedures. And the clinical folks, particularly nursing, does an outstanding job on a unit-by-unit and a nursing level to communicate more specific nursing-type communication, in addition to the credentials and the certifications and others that clinicians have to have in order to do their jobs. They have to have continuing education as a part of that, which we count toward that. And then, of course, all workforce members at JPS are required to go through a mandatory set of computer-based learning. And there's, I forget how many modules we are up to now, but there's about 15 or so modules every year that all workforce members are required to take, and they cover the gamut of all the various things from ADA compliance to privacy to a number of different things. And then my group works with HR to track to make sure all employees comply and take those CBLs. And then the last thing I would say is on compliance awareness. I'm a big advocate that training and education is the foundation, and of these 7 is the most important, because people do better when they know better, generally speaking, unless you generally in healthcare don't have bad actors that are looking to do bad things. These are caring people. They just need help understanding what the rules are. That's generally the case. And so I try to have my folks to do rounds and to go out in the hospital to make ourselves known. If they have questions, that they can ask us proactively as opposed to being an issue on the back end. And we try to do that in a fun way. Sometimes it's kind of silly, but they do kind of, I know Robert makes fun of what we do, but in a fun way, we had a pickle, we had a number of different things that we've done over the years, so. And then auditing and, you gonna say something? And then we do auditing and monitoring. And so much of the auditing that we do for this committee in particular comes to this committee. All audits have an audit report that either I present or Michelle Atkins will present that will give you what we audited and what we found. We do these audits based upon risk, and so we do a risk assessment every year. Each risk assessment is done for internal audit, is done for compliance, and that based upon those risks, then we determine the specific areas that JPS will do a specific audit. Because audits take a while to perform, and it takes a lot of resources on our part. Whereas opposed to monitors are ongoing, and so you won't see a report on monitors. You will get an update, and so monitors would be anything from what's happening in research and academic affairs that has a compliance aspect to it. Like, for example, resident supervision would be a monitor. Sometimes it would be an audit, depending upon the nature of it. And we would get these reports from various parts of the organization related to those monitors. Comes to the compliance committee. We would discuss it in compliance committee and then occasionally bring that to you all as board members as well. And then HIPAA, and of course in hospital the biggest monitor is HIPAA, and so we've talked a lot about HIPAA, and so we have a tool called Maze Analytics that we got last year that allows us to proactively monitor potential inappropriate accesses to Epic, and it has an interface with Epic, and it really helps us to do this in an automated way. Even though we don't have a lot of resources, we have 1 or 2 folks that look at this on a regular basis. Moving on, response and prevention. Essentially, that's a part of for the auditing process. Those are the action plans. Those are the things that here's what we found. What are we going to do about it? So that's the response, the organization, and it's most important, particularly for outside parties and government agencies, that if we agree that we're going to do an action plan, we have a date on that action plan, that we have to commit that we actually followed through with that. Because the worst thing to have is an audit that has action plans that didn't actually occur, because then you kind of hit yourself in the head with your own hammer, so to speak. I will say we do a great job here in following up on those. And then lastly, risk mitigation investigations. So there are matters that come to us, some of which almost all of which we talk about in this committee, that we have to have an investigation either under attorney-client privilege with general counsel or third party, that we will come and review with you as board members as well. And then lastly, enforcement. That's the kind of the distasteful aspect of compliance, but it's necessary. It's, if we do find a confirmed violation, people were trained, they were aware of it, but there's still a violation, then there has to be action taken. Sometimes that's termination, sometimes that's more education, sometimes that's, if it's a physician or peer review matter, it goes through the appropriate MEC process. So, in terms of that. So those are at a high level, the 7 elements, and I'll kind of come back to you periodically to talk about various aspects of each one. We do plan on reassessing our compliance program effectiveness against these 7 elements over the course of this next year. You tend to want to do that every 5 years or so, and it's been about that since we've done that externally. And then each of these is documented as well. I know I kind of went through that quickly. Questions on any of that? Yeah. Good question. So a claim, and actually goes to my last slide here, has its own compliance program as it relates to the physician organization. And so a claim has a compliance manager that we meet with every month to talk about where because they have a similar risk assessment. We work with them on that. They have a audit plan, and then they use a third party to help them with their audits. They also have a coding and billing auditor, similar to what we have here for the hospital, that does ongoing physician chart reviews on the claim side, and they go through that in a methodical way. They also meet. A claim also has a compliance committee that meets. I know Dan is here, I believe every other month or so, and we attend that as well. So we're looped into what they're doing, and it's very synergistic with what we're doing.
Do they have their own call-in line, hotline, or is it just one central?
It's just one central line, and so, but we've talked to our ethics point third-party administrator that if it's in a claim matter, there's a separate routing for those calls, and so that they can handle those appropriately.
Okay.
Yeah, good question. This last slide is just a visualization that compliance is more than the 6 or 7 folks that are in my group, because there's no way that me as the compliance officer can know everything happening at JPS and a claim about compliance. And so it's essential that we partner with various other aspects of the organization to get these reports, these monitors, these other reports. And I talked about the way we do that with a claim, but also we do that with research and academics, and we meet with them. We meet with the various service lines, coding and billing, privacy and security. And so when we meet as a compliance committee, we try to bring in all of these aspects and representatives from all these aspects to talk about their components of compliance, so that even though it doesn't report formally to the compliance department, we as an organization know where we are from a compliance standpoint. Does that make sense? So hopefully that was helpful. I'm going to count that toward board education, and
Oh, okay.
if that's okay.
Do I get 2 points?
You get 2 points.
Anybody have any other questions? Ron, thanks for the compliance update. Let's move now to item 5C, district policies for consideration.
All right. I'm going to have, for this one, I'm going to have David Mendenhall to come up. These are 3 security policies that are
David, you have to speak in our language.
No, because if I ever speak.
We don't understand zeros
I'll be here
and
for
X's.
2 hours, and that breaks the rules.
Well, he thought that the governance committee should look at revising the dress code to blue jeans and a jacket.
We had 2 board chairs that showed
Yeah.
up, and I think that's fantastic.
You gotta go through HR and Wanda through that, and Godspeed to you, David Mendenhall.
Wanda and Pia, no,
It ain't
never
gonna
mind. It's
happen.
not worth it. Not worth it at all. So what we've done within IT and with Ron's team is take a look at some of the policies that we had that were, number one, a little restrictive for when we needed to make changes to our technology infrastructure, and also, 2, when we have procedure changes that need to be changed, we would end up going through an entire policy review and having to come through the board to be able to do that, when really we're changing out a data warehouse software, or we're changing out something else that is very technical that really, quite frankly, you guys, I don't think that you necessarily care about what we're doing at that level, but it was wrapped into our policies, and that was just bad form. That was 15 years ago. It shouldn't have ever been that way. Now that we're re-looking at this, we've collapsed 3 policies, and I think these have to be reviewed individually, right? And we collapsed 3 separate policies into 1 policy, and then their associated procedures into that as well. So before you today for recommendation is IM 100, Security of Electronic Information. That's a policy, and then what we've done is then move in several procedures underneath that policy for requesting IT products, computing devices at the JPS network, access credentials, and also an acceptable usage procedure within that. And again, a lot of that is because we have very technical documents that are on those things, and we need to have the flexibility to be able to stretch those as well as change those with, on the fly if something comes up. Like, for instance, a couple of weeks ago, this is probably about 2 months ago, when we got hit with a potential hack that I can tell you, we did not lose one piece of patient data, not one system went down, it just slowed some things for a couple of hours. In the middle of that, it would have been very, very difficult to change out some technology if I would have had to wait on the board to act on a policy change. So hence why we needed to be able to collapse this. So in front of you is Information Management 100, Security of Electronic Information.
And I'm assuming the archival of IM 200 and 300 are the two that are now wrapped into one?
Right, exactly. And for instance, we can talk about it. So when you look at item number 3 there, that's IM 300, that the letter E, which is person of interest. That is a procedure for if someone comes into the organization that is a board member, it's an employee of the organization, or a high-profile person within the community. That's a policy that sits out there of how do we deal with that individual. That is now a procedure that is wrapped up into those other procedures so that we can do those things as we need to.
Anybody have any questions, concerns, comments?
No, I read all those policies, so I was ready for my questions.
I'll take them, Ms. DeVos. I will
No,
absolutely take them.
I didn't have any, no.
Do we need to move on each of these separately?
Each of those.
Okay, all right. Then I'll move approval on item 5C1, IM 100 security and security of electronic information.
Move approval of the policy, IM 100 security of that.
Moved by Mr. Bose, seconded by Dr. Weber. All in favor, say aye.
Aye.
Any opposed? Thank you. I'd like to see if we can get a motion to approve the archival of IM 200 Information Management Plan.
Move that we archive IM 200 Information Management Plan.
A second? Motion by Mr. Bose and approval, second by Dr. Weber. All in favor?
Aye.
Any opposed? Finally, need a motion to approve archival of IM 300 Information System Acceptable Use.
Okay. Move approval to archive of IM 300 Information System acceptable use.
And motion by Mr. Bose and a second by Dr. Weber. All in favor?
Aye.
Any opposed? Thank you, David.
Okay.
We will adjourn now at 12:45 to executive session. I don't think it's going to be a long one. I don't think it's going to be a short one. It's going to be just about right. So,
Okay.
thank you.